10% of ICU admissions are due to um, septic shock, and you have mortality rates ranging from 30 to 50% depending on which study you look at. The more recent ones will show that it's closer to 30%, and a larger portion of these are now starting to become septic shock secondary to people who've already been in the hospital for a while. And the problem is sepsis results in an increased mortality. It's not a one and done, okay, you've gotten out of the hospital, you're good to go, and increases your mortality rate for 2 years following this event. And so that's why this becomes a little important. Um, Identification of sepsis and septic shock. How would you identify someone who's in sepsis? Okay, so Q-SOFA score. Anything else?
SIRS was previously used.
Okay.
The new score, which is coming up now.
Okay, and then septic shock, kind of straightforward. You're in shock, you're not responding to fluids, and you need to compress this. But really the key piece of this is a lot of us tend to rely on these. These are just markers of how severely sick you are and how likely you are to survive this event or not. It does help you with that stratification where you are saying, okay, this person has a Q-SOFA score of 2, they're in sepsis, I need to monitor this person more closely as opposed to someone who doesn't have that score and doesn't need that frequent monitoring. But the key part of this is really identifying who has an infection, and that's where the difficulty comes in, because you can have elevated SIRS, Q-SOFA, and SOFA scores just from non-infectious causes, having an inflammatory event going on. The most strongest one we see is pancreatitis, massive cystic inflammation, not related to an infection. And this really goes back to just a good history and physical. So asking for systemic signs of further inflammation, fever, chills, dryness, usually suggestive of endotoxin release into the system. And then you have your localizing signs of infection, looking for, say, meningitis versus pneumonia. So just having Q-SOFA scores or SOFA scores that are normal does not mean that you don't have an infection that's brewing or going to active. Now, the interesting thing is you guys mentioned Q-SOFA scores. So Q-SOFA scores are actually well studied and they're well validated in ER settings in gen med flows. They don't perform as well in the ICU setting. In the ICU setting, actually, SOFA scores has the best performance. And even comparing Q-SOFA scores and SIRS scores, the SIRS scores are an easier way or a better way, a better sensitivity to identify someone who's in sepsis in your emergency room or on the floors. They help identify people earlier, but the Q-SOFA score gives a better specificity of how poorly the person might end up doing. Okay. So again, some statistics. SOFA score of 2 or more, you have a mortality risk of 10% in the general hospital population. And this is in fact greater than your mortality rate from an MI, ST elevation MI. So what drives your initial choice of antimicrobial agents? Any thoughts on this? So I've listed it out, site of infection, right? So it's not always clear when someone comes into the ICU what the site of infection might be, and that's something that confounds the picture a bit. But usually, if you're able to talk to the person, able to talk to their family, you can at least come up with a good differential. Like, okay, this person does not have meningitis, right? Or this person does not have skin and soft tissue infection. Even if you're not able to rule in exact and pinpoint at the time of admission what exactly is happening, you can at least rule out what it's not happening. And so going for your site of infection, you then, if you're suspecting a CNS infection, you would not want to use those peptides, so it doesn't have good CNS penetration. If you're thinking this person has a pneumonia, and for some reason vancomycin is listed as an allergen on their chart, you wouldn't want to be using daptomycin because you know the surfactant is just going to chew it up and is ineffective for lung coverage. So those would be, and it's like if you have a bloodstream infection, tigecycline wouldn't be an antibiotic of choice. I would never want to use it as a sole agent anyways to begin with. but it just has really poor serum concentration levels. So those are things you keep in mind when you're thinking about your site of infection. Then causative organism, and this can be a bit tricky. Sometimes you have that data from the get-go because the person, you know that the person has MRSA, they've been on the floor, they've been giving them antibiotics, but now the person's gotten sick and has come up to your unit. So you want to make sure that whatever the person had and whatever information you have to begin with, you're already taking care of that piece of things. And why is the person failing now? Have they gotten a super added infection? Do you need to change the antimicrobial regimen? Or is it that this was maybe a visa and now the vancomycin MIC was maybe more than 2 and so it's starting to creep up. So those are things to keep in mind. So if you're someone who's on antibiotics on the floor coming to you in the ICU, the one thing you want to ask yourself is this antibiotic failure? Usually it's not. Or is it something new that is happening? If you're hinging on the possibility that this is antibiotics, that okay, whatever is happening is something that's not covered by, say, vancomycin sourcing. Person has intra-abdominal fluid collections. They initially sampled it. They grew an enterococcus, put the person on vancomycin. You're not getting clearance, you don't have source control. Chances are this person has had selective antibiotic pressure over a period of time, and now you're trying to see BRE. It could be featured. You want to then consider moving over to linezolid. So those are things to keep in mind. This here is a big theme of mine, patient allergies, because everything gets listed as an allergy, right? Ciprofloxacin, vomiting, vancomycin, red man syndrome. These are not allergies. So just, it takes a little bit of time, but all you need to do is click on the tab that says allergies and you'll see what the descriptor of the actual allergy is. And sometimes we lose out on using really effective antibiotics for our patients just because of an allergy that was entered at some point of time and keeps popping up in the chart. And really, if you want to use penicillin, all you need to do is get allergy and immunology involved, make sure that it's not an IgE-mediated reaction, and if that's the best drug of choice for your patient, that is something that can be done. Not in the middle of the night, though. Patient comorbidities and past cultural disease. So this piece of it becomes important when you're thinking about, say, potential drug interactions. So with linezolid, you know that there's a higher risk of SSRI, serotonin syndrome with SSRI. So you want to check, is this person SSRI? Should I be using linezolid? Should I be using actomycin? Or maybe ceftaroline, maybe that's a good option. So just keeping the person's underlying conditions in mind. Same thing with if they have deranged renal function, amphotericin may not be the best choice for them, maybe you'd want to use microfunction. And then past culture history. So for me, the easiest way I have found to access past culture history without clicking multiple times is to go into portal, pull up the blood culture, and if there is something wrong, there'll be a flag next to it. So you can just selectively pick the ones that have flags next to it and see what those culture results were. And that helps you, especially if you have someone who's got, say, cystic fibrosis or bronchiectasis, has had repeated infections, has had like stenotrophomonas or things in the past year. You'd want to know that this person's sick and septic shock. I don't want to take the risk of waiting to find out what it is right now. I will cover this from the get-go. And then your biggest help is going to be your hospital antibiogram. And I will show you how to access that if you haven't yet. So this is a table, very busy slide, but I really liked it, and the reference to this is at the bottom of this presentation. So it was in GIB. It was an article on septic and septic shock and initial choice of broad spectrum antimicrobial coverages, and they listed by organ system, what like infection, and then what you would use, and then the caveats against it. Okay, so this is just FYI. We have a very good antimicrobial guideline on the front page of this US system as well, and so that's another resource you could consider. Now, going a little broad, when would you consider an MRSA coverage for your patients? Any thoughts?
When you're suspecting pneumonia, there are risk factors.
Okay.
Those are the risk factors.
Okay. So really in our ICU, it would be very, very unusual to have someone not on MRSA coverage. Most ICUs. It would have to be your young, healthy individual, not been hospitalized, not had antibiotic exposure, comes in with the pneumonia. This is CAP. Strep pneumonia can kill people. They can put people in septic shock, but we don't need to cover for MRSA in that situation. Um, but then what the risk factors are, so recent hospitalizations, skin and soft tissue infections, antimicrobial treatment in the past 30 days. So your indwelling hemodialysis catheters actually increase your risk by 100-fold to develop an MRSA infection. HIV infections, these depend on what your CD4 counts are, less than 50 increases your risk, viral loads more than 100,000, and if you're on ARVs or not. IV drug use, research surgeries, communal living situations. So then you talk about your long-term care facilities, incarcerated military service. And sometimes for younger people, you think about things like maybe they're doing these high contact sports and they get frequent folliculitis and maybe they have recurrent MRSA infections. And the other thing to consider is if more than 10 to 20% of the staph aureus isolates in your ICU or methicillin resistance, or if you don't know the prevalence of MRSA in your ICU or in the community surrounding your hospital. Those would be reasons to give MRSA coverage. What about double gram-negative coverage? Any thoughts on that?
So the one is reflective shock, but you know that it's a gram-negative bacteremia, and we need immunoglobulins available.
Okay,
Previous history of resistance.
okay, yeah. So you can't really go wrong with this because how the ATS-IDSA 2016 guidelines framed it, at least for VAP, what they said is everyone who has VAP and who is in ARDS, is in septic shock, is, and they have a list of things like hospitalization greater than 5 days, acute renal replacement therapy, and if you have more than 10% of your isolates, which are gram-negative isolates resistant to a single agent that you plan to use, then you should use double coverage. But to be honest, this is a little controversial, probably should not have been mandated like the guideline, because if you look at it, it's a very weak quality of evidence. It's a weak recommendation. There have been no good studies to show that double coverage necessarily improves your mortality outcomes. And then when you look at the diagnosis of VAP itself, there have been studies which show around 40% of VAP is initially misdiagnosed. So what you say is VAP, 2 days later you're like, oh, this is probably not VAP, because the white count resolved, the infiltrates are no longer there, so maybe the person had something else with just pulmonary edema. And so 40% of the time the diagnosis is incorrect. And then out of the remaining 60% out of this remaining 60% of them are going to be having gram-negative pneumonia. Out of the 60% who has gram-negative pneumonia, 10% might be Pseudomonas. And out of the 10% that does have Pseudomonas, an even smaller percentage is going to be resistant to your primary agent. And usually what ends up happening is people who are resistant to, say, a if someone has a Pseudomonas that's resistant to a carbapenem, that's resistant to piptazo, the chances that it's going to be resistant to a fluoroquinolone, which is what ATS and IDSA has recommended us to use, is pretty high. It's almost like 80-90%. So do I routinely put everyone who comes in with a diagnosis of VAP on double coverage for gram-negative bacteria? No. My preference is to kind of watch and see what they do. The other thing to keep in mind is usually when an antibiotic and a microbe has acquired all these resistance genes, their fitness factors also go down. So you're talking about E. coli normally having a doubling time of 20 minutes. When they acquire these resistant factors, either through chromosomal mutations or plasmid mutations, or plasmid transfers, their fitness factor, they don't double as quickly. So that's another thing to keep in mind, it's not as fit. So if the person is not in septic shock, not on 2 pressors, and you're thinking this is MAP, or maybe they've been in the hospital for a while, maybe they're draped and peg, and nothing much has changed other than a white count and a slight increase in their WBC count, I wouldn't be initiating double coverage. Maybe if they're two pressors and pressor requirement is heading up, I'd consider, okay, you know what, because what the studies definitely have shown you when we've used double coverage is increased risk of renal failure.
But if you recommend double, but because I've seen patients like septic shock refractory and they eventually passed away from gram negative. Would you recommend like Zosyn or like carbapenem plus immunoglycoside? Like, because as you said, terophenols are going to help.
Yeah, so yes, if you're going to commit to it.
Yeah.
You said, I think there's a resistant bug, commit to it, and we'll go with the antibiotic when I have a screenshot of that, okay? Now, this is another piece of it. When do you want to add on antifungal coverage for your patients when they come in? Thoughts? I know lots of it up here, but when do you think about, okay, maybe I need to put this person on antifungal as well? Perforations, yes, that's fantastic. Anything else? So TPN, they have a line, they're on TPN.
If they don't improve,
Sorry?
if they're not improving
Okay,
with like whatever coverage you're giving, then you can consider adding antifungal.
okay.
Leukemia patients.
Yes,
Surgery.
for non-transplant patients, yes. Transplants, neutropenic patients. The last two things I've listed, recent broad spectrum antibiotic coverage, exposure and colonization of multiple sites. So those are slightly weaker risk factors, which may not necessarily reflect that someone has a candida infection per se. All that usually means is that you've pretty much wiped out their bacterial flora with your broad spectrum antimicrobials, and now candida is the thing that's proliferating because its growth is unchecked. And so that's what this usually is a reflection of. And even if you look at the studies, the question is it just a confounding factor? Is this just a reflection of how sick the patient actually is? And for example, when you look at studies that have been done on people who have got candida pneumonia, and then they do autopsies on these people, and these are people who've had like BAL confirmed candida pneumonia, and then when they actually do the autopsy, a very, very small percentage out of like 800, the sample size was around 800, that they studied a very small percentage, around 5, basically had actual acute inflammation with candida in their autopsy specimens. So it's pretty rare. So it's more of a zebra if you're thinking this person has a candida pneumonia, candida UTI, but they don't really have the risk factors for it. You might want to make sure you're not missing out on anything else that's happening. That being said, unlike other, so there's a lot of scores, right? It's like sort of screening tests that you can do to look at what is the likelihood that someone has an MDR, or what is the likelihood that someone needs a blood culture. This scoring system is for everything. But the Canada scoring system is pretty well validated, and it's well validated in ICU settings. So that's why I put it up here specifically. So you're looking for someone who's had recent surgery, multifocal colonization, TPN, severe sepsis. So severe sepsis by itself gives you a score of 2. And then if you hit any of these, then you get 3. And above 3, what it gets you is there's an increased benefit in trying to cover for antifungals at that point of time. So that would be something you can keep in mind. And also when you choose your antifungals, I would personally want to go with a kind of candidate like mycofungin or caspofungin, just because they're well tolerated in renal dysfunction, which is what a lot of people with sepsis and septic shock end up going into. And you don't need to adjust the dosages for that. Amphotericin wouldn't be my first go-to unless I'm suspecting that it might be an organism that's resistant to any kind of candidate. And azoles can also be used for hemodynamic stable patients. And then just this real quick slide on antimicrobial resistance in the ICU. So you have your multi-drug resistant organisms, which is resistant to at least one agent in 3 classes. Then extensively drug resistant were resistant to everything except agents in 2 drug classes. And then pan-resistant where they're resistant to almost like everything including colistin. So those are your 3 categories of drug resistance, and it varies depending on which country you're in, what is the resistance pattern in that country, in that geographical zone. Like for example, in Greece, the carbapenemase resistance is mostly oxa 48. Here in the US, we mostly have KPCs. If you go to Southeast Asia, it's mostly going to be NDNs. So those things are going to, those patterns are going to change depending on where you practice. The big thing to keep in mind is your escape organisms. So these are the most likely ones to account for a large number of resistant gram-negatives seen in most ICUs. So Ephesium, Staph aureus, Staph aureus is not gram-negative, but Klebsiella pneumoniae, Acinetobacter, Pseudomonas, and your Enterobacter species. When you look at ICU infections and reasons for people coming to the ICU with septic shock or sepsis, 65% of the infections were due to a respiratory etiology. And 20% of them were due to Staph aureus, 80% of infections were due to your gram-negative organisms. So just soundbite for Candida auris. Anyone here practice in New York or familiar with Candida auris?
Is Detroit, not Detroit, Michigan right now.
There was one in DC also. There was an outbreak in the nursing home.
Okay.
And then they were doing rectal swabs in the hospital. Yeah, like this was like 2 months ago.
Okay.
But yeah, that's all I know about it.
So, okay, so basically the big thing about Candida auris is it hit New York in, I'm going to say 2015 or 2016, and then it subsequently spread. It started in Southeast Asia, I believe, and then moved across. So you're starting to see it more ICUs. It's basically Candida fungus that's resistant to amphotericin. The initial agent of choice would be any kind of candid, but then we're also starting to see pan-resistant ones, which are resistant to all 3 classes of antifungals. So that is Candida is something to keep in mind. And like I already mentioned, this is when these antimicrobes get these resistance genes, either via plasmids or chromosomal mutations, is always a fitness cause where there's loss of some essential genes. So there's then going to be decreased growth rate, decreased competitive ability, and or virulence that happens. So where is our antibiogram? And I put in the screenshots, but then I realized you can just share the location right over here. So I'm just gonna go from here. And it's going to be different in different places. So when you work in the VA, they're going to have a different system of where you could potentially locate all this information. They're going to have different, and we'll talk about that later, different ways on how to de-escalate your antimicrobial therapy. So here, what you want to do is basically go scroll down from your front page to clinical resources, go to infection control, antimicrobial stewardship. It's fantastic. It's a fantastic resource. Really, the only piece that's a little annoying is the number of clicks you need to do to get to it, but otherwise it's really good. So you have your antimicrobial stewardship pocket guide over here, and then you have adult infection treatment guidelines for almost everything, and dosing guidelines for other drugs, pathways, when to use procalcitonin and how to use it, and all the antibiograms. So this is the most current one, is the 2020 antibiogram. And so let's go back here. So this is our 2020 antibiogram specifically for the medical ICUs, and so that's on page 6. Includes your gram negatives, gram positives, It's a 46-page document, so if you want to go into all of this in a little more detail, you're always welcome to, you know where to find it now. But I'm just gonna hit on the highlights. So if you look at your IDS ATS guidelines for when to use gram-negative coverage, it says that if you're in an ICU where more than 20% of your isolates, sorry, 10% of your isolates are resistant to your monotherapy agent, then you might want to consider adding on a second agent. So that's the reason I said you couldn't be wrong if you decided you wanted to do that, because looking at, say, Pseudomonas, which is what we look to cover most of the times, we had 132 isolates collected and then 62% of them was only susceptible to Zosyn. And the reason we mostly use Zosyn in our ICU is because meropenem is even worse, it's at 57%. So you wouldn't want to use your meropenem. Usually your agent of choice is going to be Zosyn. Now, if you're going to commit and say, I think, and I already gave you the stats of what percentage of your VAPs are actually VAPs, and then what percentage of that is going to be gram negatives, and then what are the chances that's going to be a resistant Pseudomonas. So if you're going to go down that and say, okay, you know what, this person's not doing well, I think I have a resistant Pseudomonas in my hand, and commit to giving them a double coverage, you really want to go with amikacin, because look at the numbers over here. Even if you think it's not Pseudomonas, it's some other resistant gram-negative, maybe it's a Klebsiella, you're hitting everything in the high 90s over here. Okay. You'd want to get pharmacy and make sure you're renally adjusting your doses and doing it appropriately, just given the fact that renal toxicity and most of the people are going to be elderly. So that is the highlight on the gram-negative page. Now going into your staph and enterococci. So if you look at staph gram-positives, 120 staph aureus, so that is majority of your gram-positives that are going to be coming up. Only 46% is MSSA, so more than 50% is MRSA. So you definitely want to have MRSA coverage. And for me, what is interesting is if you look at the ATS IDSA guidelines, the double coverage for gram-negatives comes up as a weak recommendation. MRSA recommended coverage comes up as a very weak recommendation, which doesn't make a lot of sense because most of the people in the ICU infections are lower respiratory tract. Out of that, majority are going to be 20% is close to MRSA. Pseudomonas, you're talking about a much smaller percentage. So, and then given our antibiogram, where less than 50% are susceptible to staph, I definitely want to have MRSA coverage on board. Also, keep in mind if the person has ephesium or you have a person on vancomycin, they have some sort of intra-abdominal pathology, and you're thinking, oh, I have all my intra-abdominal bugs covered, I have vancomycin for my enterococcus, I have Zosyn for my gram-negatives and anaerobes. Your patient is not doing better, they're not turning around the way you're expecting them to. One thing to keep in mind is your ephesium, basically just 11% of them are susceptible to vancomycin. So then at that point of time, you might want to consider switching over to leading solid. Okay. And this also becomes helpful. You're looking at the cultures every day. You don't necessarily need to wait for the final results. Just looking at the gram stain, seeing what is there, especially if your patient is not doing well. I prefer to wait for the final results before de-escalating and completely narrowing down to a single agent. But if your patient is not doing well, just small things like looking at your gram stain, looking, is it gram variable, is it gram negative, is it non-fermenting? Those prelim pieces of information can be very helpful to help you decide, is this, do I need to broaden my antibiotic coverage or not? Now, going a little bit into timing of antimicrobial agents. So this is a slide I love. It's a Seymour article that came out in NJM in, I'm going to say 2014, basically looking at time to completion of the 3-hour bundle. Okay, and they looked at all the hospitals in the New York Department of Health database, and they looked if you look at your x-axis, it's time to completion of your bundle, y-axis is your in-hospital mortality. So this bundle includes fluids, pressors, lactate checks, antibiotics, everything. And look at the curve over here as time increases, as the longer you take to complete the bundle, the higher the mortality becomes. But then when you look at time for administration to antibiotics and time to completion of the bolus, really the difference is basically about time for the administration of the antibiotics, because whether they took 1 hour to complete the fluid bolus or 12 hours to complete the fluid bolus, the mortality rates pretty much stayed the same. Whereas whether they took 1 hour to complete the initial antibiotic dose versus 12 hours, that actually produces a pretty big difference in the mortality rate that patients can suffer. Now we'll talk a little bit, I'm sorry, I'm running a little late, but plans for de-escalation. So de-escalation is something you need to be thinking about even before you get to that 48-hour mark. Like when you start initiating broad-spectrum antibiotics on a person is when you need to also be thinking about how am I going to be de-escalating it. Thinking about it 48 hours later is not going to be helpful or useful to anyone. So cultures. So you can, depending on your source, depending on what you think is the cause, blood, respiratory, urine, stool, or the body fluids. So the problem and the things to keep in mind is blood cultures are usually the gold standard we go to. But how effective are they really? Not very well unless you're going to collect multiple blood culture samples. So each bottle gets around 10 cc of blood. So a set aerobic, anaerobic will get you 20 cc of blood. So you really need to collect around 40 cc of blood to reach sensitivities of close to 98%. And then we're talking about actual full collections, not someone put 5 cc and 5 cc of blood into 2 bottles, because the more you dilute it, the less chances you're going to have of recovery as well. So this is about talking about bacterial infections. When you talk about fungal infections, the sensitivity of blood cultures is actually closer to 50%. And so that's not great, is it? So one of the things you then want to think about is other tests, and I'll go into that in a little detail later. So the other thing you want to think about collecting is procalcitonin. Like I said, the website has a good page on where to collect it, what situations to do it on. But most of the time I found that patients get admitted at night, we don't have a good source of what's causing the infection. It could be a UTI, it could be pneumonia, it could be some sort of abdominal infection. The workup is still going on, but the person's already started on broad-spectrum antibiotics. So you want to make sure that you have that lab test already sent out in advance. So how is this procalcitonin going to help? It's well studied in ICU populations, well studied in respiratory tract infections, and it's always something where you de-escalate based on the procalcitonin levels. I would never, in an ICU setting, I wouldn't use the procalcitonin to decide whether to initiate antibiotics or not. And it's something you use in the broader context of how the patient is doing. I would never say, oh, the patient's still on 3 pressors and the white count is going up, but you know what, the procalcitonin level is less than 0.25, so let me go ahead and stop the antibiotics. That would not be the scenario I'd use again. And so the reason I just pulled up this particular table from the ProRata study, which is where a lot of the gold study that gave us procalcitonin data. They used it on different infections, 300 in each group, and around 170 of those people in each group had mostly respiratory infections. So the early studies that were done were mostly done in ED settings, respiratory infections, should this person with CAP be going on with an antibiotic or not. Again, ProRata study, they studied it across all infections, but when you look at the end analysis, most of them are respiratory. Downsides of this study, if you come across, is not everyone followed the algorithm. So 50% of the time, clinicians decided they weren't going to go with the algorithm, they were going to use their clinical just out. The other thing that I've come across where people have criticized the study is it was a non-inferiority study. So they were looking for a difference of around 10%. So when you look at this mortality group, you have mortality in the procalcitonin group versus mortality in the control group. And there are a lot of people who said, well, if you use tighter controls of closer to 5%, then maybe we would have seen, it wouldn't have been as significant of a difference. The end is, if you look at all of these studies which have looked at antimicrobial de-escalation and decreasing use, they've been very effective in actually decreasing the use of antibiotics, total antibiotic days. This 20% less antibiotic usage as compared to the control group. What we haven't seen really is improved mortality, less rates of C. diff. All these things that we're actually aiming for are things we have not really seen in these studies. Some of them may be because we haven't studied it out far enough. So some antibiotics by itself, like cefepime, for example, it can inhibit Clostridium difficile, and so you see the effects of the antibiotic use and possible C. diff after you then remove the antibiotic from their system. So maybe we've just not studied it out far enough, but we haven't, other than decreasing days of antibiotics, we haven't really shown an improvement in C. diff rates and mortality outcomes. The other one is, and this is something we're going to be rolling out more consistently in our hospital in the coming year. So using MRSA NES as a marker to help you de-escalate vancomycin usage. So just really quickly going over it, culture is less sensitive, your sensitivity is in the 80s%, with PCR sensitivity goes up to the 90%. Low prevalence settings, you have a negative predictive value of almost 99%, that this is not MRSA. Your negative predictive value goes down in high prevalence settings. So in ICU settings where you might have closer to 30% of MRSA infections, your negative predictive value may be around 89%, which is still very useful to help you decide to de-escalate your MRSA coverage or not. In pneumonia, so this is your CAP, HAP, and HCAP. And all of the negative predictive values in this study, they had a 4,400 cases was in the 90s. There's the most recent paper I saw on this was sometime in June of this year, 5,000 people, but that was in a high prevalence setting, and they actually focused a lot more on the positive predictive value of MRSA. I focus more on the negative predictive value. So if it's not there, it's not there. Your patient's doing well, I would say take off the vancomycin and see how they do. And if they continue to be on an improving trajectory, okay. If you have MRSA on your nasal swab, it doesn't necessarily always correlate to what's actually going in the lung. Does that make sense? Yes. And then beta-glucan. So the reason I'm talking about this is I told you briefly about how fungal cultures really do very poorly. They're not very sensitive. So in Europe, they actually do antigen antibody testing looking for markers of fungal infection. So mannan and anti-mannan levels is what they use over there. Those tests haven't been validated. They're not in use in the US as yet. What we do have and what we can use is the beta-glucan levels in serum. Advantages is sometimes these levels start to rise even before you start to get positive blood cultures, up to 7 days earlier than the positive blood cultures actually turn up. The downsides of it is it's great. So your beta-glucan is going to be negative in a healthy individual if they do not have a fungal infection. The problem in the ICUs is you have a lot of confounders. So things like mucositis, just gut translocation, having gauze with glucan material in them, use of albumin, use of antimicrobials like amoxicillin, clavulane, tryptase or less nowadays, but all of those are things that can confound the beta-glucan levels in serum in the ICU. So it would be good to check it if you're going to commit someone to an antifungal agent, but also know how to interpret it down the line in the view of these multiple confounding factors. Again, not well studied in patients who are neutropenic, which is the patients you use it most on. and people who have structural lung disease and things like that.
We don't have the T2 score here, right? The T2 score, PCR, Canada.
PCR Canada, no, we haven't used it already.
And the confounding factors, like, does it become like positive or negative?
It becomes positive.
Okay.
Even an antibiotic makes it positive.
Yes, so Zosyn, but the way it's being manufactured nowadays, less so. But amoxicillin tablets, it's not really available in IV format in the US, but that continues to confound BWD
But is there a level like we say, no, this is not co-founding, this is a real infection?
That's a good question. I don't think so.
Thank you.
Any questions? Any other questions?
Sometimes with these culture sensitivities, we get all these MICs.
Mm-hmm.
I know, like, usually you don't compare between antibiotics.
Yes.
It's particular for that. Do we go by?
It's particular for that bug and for that antibiotic.
Right.
Okay.
Do we use that in titrating medications in the ICU?
Not usually, no, we don't. So the only time you think about that is like I mentioned, vancomycin, your MIC cutoff is actually 4, but there's increased failures once the MIC is going to 2 and above, and then you start thinking about intermediate resistance, your V cells, and the problem with that is what is starting to happen is there's thickening of your cell wall as well, and so sometimes people then switch to daptomycin, but the mechanism of resistance is still the same. The daptomycin MIC might be okay, but the chances that the person could fail daptomycin therapy as well is also then a little higher. If it's getting to that stage, I definitely get IV involved at that point.
Do we do continuous antibiotic treatments?
We can, and I'm glad you brought that up because I forgot to mention it. So that is one way. So when you're looking at antibiotics, your beta lactams, your kill efficacy is really based upon time under MIC. So one way to improve that, and most of our ICU patients, you're not so worried about getting adequate concentrations because most of them are going to renal failure, it's actually starting to accumulate in your system. The chances are you need lower doses than higher doses, but there is a subset of people who actually have faster clearance. And by then, and since we've not reached a phase, the time in medicine where we're able to individualize that sort of therapy, we do sometimes use continuous infusions of like Zosyn and things like that. The problem with that is, again, that we use it on our sickest patients who already have multiple lines, and now we're committing an entire IV access port to just Zosyn usage. So it's not something people jump to from the get-go, just because of they're talking about committing one line to that. But yes, it has been used, and it's actually more effective than intermittent dosing of Zosyn.
One last question.
Sure.
We cannot use Eraxis for CNS coverage, right?
We cannot use
We
one.
can use Eraxis or that's patents for CNS coverage. Do they have with CNS
No,
coverage?
CNS you want to use amphotericin.
Oh, wow. Oh. But otherwise, if you're thinking from Union, use those
Yes.
rather than acyclovir.
Yes.
Thank you.
Oh, you're welcome. Thanks.
Thanks, Dr. John.
Oh, thanks.
Yes.